Okay, great. Well, thanks for coming for Sushi Lunch and Nursing Rounds. And I'm going to tell you a little bit about one of the projects that I've been working on. So this is around a hackathon that I went to in December because of some work that we've been doing with the electronic medical record data. So just in case you were wondering about what is antimicrobial resistance, it's a big, huge problem in Canada, as well as actually it's a global problem. And antimicrobials across the world are becoming increasingly ineffective. And right now there's about 26% resistance rates to all first-line antimicrobials in Canada. The cost of AMR to Canadians right now is about $1.4 billion, and it's mostly because they have extended hospital stays and there's lengthier treatments that end up happening. Antimicrobial resistance is attributable to about 700,000 deaths globally and greater than 13,000 in Canada today. And so it really threatens the economic growth of our country and stability, and it also increases social inequalities and causes significant disruptions to society. So it basically ties up the healthcare system, and you can see this happening because if you just think about COVID-19, you know that just that alone, it has affected, I guess, about 78,000 people. It's really tied up the healthcare system, and it's going to slow tourism growth, and it is also shutting down borders. So that's just a very small problem compared to antimicrobial resistance. So actually by 2050, they think that if this continues on its curve, that it could cost as high as $8 billion to the, and mostly to the healthcare system, but also just in lost productivity, et cetera. So it's a big problem. It does keep people awake at nights, and I know that this is a big issue at CIHR, even though they don't talk about it as much. Antimicrobial resistance is also it's called a one health problem, meaning that it just doesn't just affect humans, but it affects anything that gets antibiotics. So anyone that has a pet, the veterinarian practices, agriculture is obviously a big one, where they use antibiotics, and you know, the antibiotics get into the food supply chain, et cetera, et cetera. So we were interested in looking at how can you tackle AMR in primary care. So the reason why we were interested in this is because for every person that gets hospitalized, there's about 46 people that end up going in to see a primary care clinician. So we think that this is a very important problem that maybe you could start to bend the curve in terms of antibiotic prescriptions being given in primary care. So, and so we came up with a solution which I'm going to show you, and I'd love to get some feedback on what you think. But first, I'll just switch to telling you a little bit about the BC healthcare environment and why we think this is feasible. So one of the things that we are doing in British Columbia is we're creating a health data platform, and we want to try to create a learning healthcare system for better health and healthcare outcomes. So the province is spending a lot of money creating this data platform, and it becomes a public asset, and there's a bunch of data that go into it. So all of the culture and sensitivity data from antibiograms will end up being in this health data platform in the federated environment. And electronic medical record data could also be incorporated into this health data platform. And in the health data platform, you see that there's data that is being put in there by health authority data, so that's the hospitals, et cetera, as well as the Ministry of Health, so that could be like billing data and stuff like that, and then also specifically through the CST system. So electronic medical records is but one part of the ecosystem, but it's an important part because it's where primary care is delivered. And then eventually you would be able to add the consumer wearable kinds of things if people, once they work out all the privacy and consent issues, et cetera, et cetera. So the idea is to create an information infrastructure that would then help the healthcare system become a learning system where people are not working in silos and information isn't kept in silos. Because right now, when you are on a hospital ward, you get to see what's going on with that patient, where they've been in the hospital, but you have no idea what's going on with them in the community or what other kind of services they're interacting with. So we have no data at this point in terms of where they're getting their prescriptions filled, who's doing the prescribing, et cetera, as it relates to antibiotics. So this is a current use case scenario with electronic medical record data, just to show you that this kind of thing can happen. So this is looking at people who have been recruited by a PI in the hospital setting. These are Hep C users, and then they're going into a clinic in the hospital, and then they have been consented to say, yes, we can share your data, and you can go and get our data in the community. And then I'm on the sort of the community end and working to recruit people into this network called the Canadian Primary Care Sentinel Surveillance Network, which is where the AMRs are. And we're then going to link that, we're going to create a link data set for this particular PI, where it's their patients that have consented to have their data looked at across both the hospitals and what they're doing within the system. So we're just part of that system, and then they're going to look at health outcomes and healthcare utilization. The other thing that is really interesting with the electronic medical records is that you can also see what goes on and by whom the care is being delivered by. And so this is data that comes out of electronic medical record, and this will really help us to understand who's being seen. In this case, you can see in terms of the chronic disease profiles, there's different bars, and the different colored bars are the different kinds of providers that are providing the care. The orange ones are the nurse practitioners, and then the gray bars are the nurses. So you can see that for these chronic disease profiles, this is data coming out of Ontario, that nurse practitioners and nurses are seeing people all across the board in terms of these different chronic conditions. And then we also know some information specifically around pharmacists and who they are providing care for. And sort of the slide on the little bit on the bottom is basically showing you what happens with when people see physician-only care, and then when they see physician and another healthcare provider. And what you see there, you can't see it, the writing or anything, but what happens is the mean emergency department visits and then the mean number of hospitalizations decreases when they see a physician plus a healthcare provider. And this is for people who have a chronic condition. So these are just sort of setting up for you what can we do with electronic medical record data. So getting back to our problem, which is how do you bend the curve in terms of the prescriptions that are happening with antimicrobial resistance. So right now, a person comes in to have a prescription written, or they come in with a urinary tract infection. So they're coming in with pain frequency, and they're wanting to see their doctor. So, Joe, the doctor, needs to write an antibiotic prescription for a patient with a UTI. And in the electronic medical record, this is what happens today. So it's basically an electronic form, and the physician or the nurse practitioner is sitting there looking at their app on their phone and trying to decide, okay, what's the first line antibiotic, and what's the dosage, and et cetera, et cetera. And they literally are typing this in into the EMR. So great, it's coming out in a typed form that the pharmacist can then read. But basically the prescriptions are written in as free text, and they require active selection of an antibiotic every time. And what we know is that in primary care, the clinicians are really busy, and there's a lot of what we would call cognitive overload. So the theoretical framework behind this is that there's a lot of cognitive overload. So we want to create a solution whereby it's really easy for prescribers to use something that's not so time consuming, and it decreases their cognitive load, because the fastest way to get rid of someone is to just simply give them an antibiotic and move on to the more complex patients. So that is really a reality when you're working in primary care. And we know that there's been studies that have shown that clinicians show decision fatigue over their working day, and they will prescribe more prescriptions at the end of their day. This is showing, you can see the dark blue is antibiotics sometimes are indicated, and you can see that at 8 a.m. they're doing pretty good. But as the day wears on, the antibiotic prescriptions, even for the dark bars, are going up. And then you can see that the square ones where antibiotics are never ordered, they're pretty good at 8 to 9 a.m. in the morning. But then what happens at the end of the day, you see that there's going to be more antibiotics that are ordered. So that's not good. So this is a solution that we wanted to try to understand whether we could fix this without really trying to go into a lot of behavioral change management, if you will, right? Because it's hard to change prescribers or clinicians' views on how they deliver care, because they learn it a certain way, and then they get into a groove. They've got 15 to 20 patients coming through their door, and they're just going to do what they've learned. So what we came up with in the hackathon, we worked with a multidisciplinary team. We had bioinformatics people on the team. We had a data visualization person, a family physician, myself, and someone from a public health agency. And we all got together, and we wanted to come up with a way in which you could look at the data and then make it easy for them to prescribe the right antibiotic. So I'm not showing you the little interaction part of this, but basically, so you go into this module. So this would be a module that's sitting within your EMR, and you would put in the diagnosis, and then as soon as you put in the diagnosis, then you get to whatever your treatment options are, which is over here in number 2, and it would recommend for you what the first line treatment is based on culture and sensitivities that have been done within this person's electronic medical record, but also based on community antibiograms that you would have gotten from your health data platform. Because the antibiotics, the first line recommendation of antibiotics should be locally tailored so that you're taking into account the local culture and sensitivities of the antibiotic, because it could vary from region to region. So for instance, this first line antibiotic may be different if you were a woman with a UTI coming in to see a doctor in the Fraser Valley where there's lots of agriculture and lots of antibiotics maybe being used, versus if you were in a small town in the north. So it could differ. So then what happens is it recommends this for you, and then you can choose as a clinician to generate the prescription, and it would just kind of spit it out, so it wouldn't be actively typing everything in, or you could send that prescription. But you also, as a clinician, would get to choose if you wanted to use that first-line antibiotic, or no, I really want to use Cipro because that's what I always use. And so it shows you in number 3 here, you would have right away, it will show you what your prescription behavior is compared to other clinicians in your area for second and third line antibiotics. So you have, you're providing a decreased cognitive load and making it really easy to choose the first line antibiotic, but you're also allowing choice and showing clinicians feedback on what their prescription behavior has been in the past in terms of second and third line antibiotics. So they could still choose it, it would just be many more clicks. So when we actually did a sort of a, I don't know, a simulation study of how many clicks does it take to get to a first line antibiotic, it took the clinician, I think it was like 35 clicks through their EMR system. And this literally would be kind of a 1 or 2 click kind of system, if you could get it down. So that seems really appealing. And we actually we tested this on a different family physician, and that's what we got from her was that she thought it was great, and she would definitely use it with her residents. So it could also be a good teaching tool. Right, so then this sort of shows you what happened on the back end. So you have these different EMRs, and they would you'd be able to prescribe within the EMRs your antibiotic, and then this data would then feed back into the health data platform, and then the community antibiograms also feed into the module. And so if you imagine multiple different EMRs doing that, then you actually have a system that would continually update. So it is possible to do. It is feasible to do. It's just a matter of other things that go on. So just a little bit about, okay, what is this EMR? How do you do it? So this is the Canadian Primary Care Sentinel Surveillance Network, and it is a network of networks. We have one in British Columbia, and it's in 8 different provinces and 1 territory across Canada, and it's located at UBC here, and it's part of what we call the British Columbia Primary Healthcare Research Network. And then those are the funders. So it's funded by the Canadian Institute for Health Research and the Michael Smith Foundation, and it has tripartite leadership. So the data is stored at UBC. It's compliant with relevant privacy and security legislation. It's protected behind VPNs and firewalls, and then there's there's privacy and security training that go along with it. So what it does is it creates this high quality, cleaned and coded, de-identified primary care database for purposes of research and surveillance. But at the clinical level, you can re-identify the data because you can then use it for quality improvement purposes. So it extracts out of the different electronic medical records in the environment. The ones that are in bold are the ones that we currently extract data out of in British Columbia. So we do 4 different systems at the moment. And then, as I said, it can be linked to other data in the system. And we could do this through the Population Data BC, which is another resource that we have here at in British Columbia. And this is the kind of thing that it would extract data on. So it extracts data on these kinds of, they're in tables. In an electronic medical record, all this data sits in tables. And so you can see the lab results is where we would get the culture and sensitivity for. So this is a grant that I am currently working on right now to try to get some money to take this to the next level. So we created a little application, if you will, as a pilot. We had a panel of judges, and we actually just went there to see if we could get a good grant idea so we could put it forward. And we actually ended up winning the competition, so that was pretty neat. So it's pretty exciting because I do think that there's potential in this idea, and it takes a range of different people in order to put something like this together. So I guess you could call it simply a clinical decision support tool that's available for clinicians, but we also think it could be used in terms of communicable, non-communicable disease surveillance, as well as it would be really helpful for clinicians thinking about their cognitive load and trying to decrease the number of prescriptions that are either inappropriate or ineffective. So this would be one solution. I mean, if there were really easy solutions to the AMR problem, I think they probably would have been solved by now, but there isn't. And what's really exciting, and I think we're trying to also think about, is could you take this and also move it into the veterinarian world, where we know that there's a lot of antibiotics that are also taken. So I do think that there's multiple different ways to kind of look at this particular problem. And it's all kind of based on, there's clinical knowledge that's needed because you think about the cognitive load stuff. There's the informatics and the computing to get to this. And then there's also microbiology to understand what the lab data is trying to tell you, because I certainly have no idea about the microbiology and the CNS stuff. So we've been working with the Public Health Agency because they're very interested in not necessarily monitoring the things that the physicians are looking at this point, but they're looking at sort of what are the new and emerging culture and sensitivities. So yeah, so that's my presentation.
I have a question from the
yes.
remote audience already that
yes.
Feeds into your kind of last comment there about whether you could comment further on the knowledge base which is used to define the local area treatment options, example, small town versus urban, and was this data driven from Pop Health?
Yeah, so actually we went to the hackathon with data, and the data was extracted out of the BC Citizen site and also out of one of the Ontario sites. So it came from, so in British Columbia, we have just one big network. So it was all the people that participate in Citizen. And then in the other site, it was more of a smaller town. But what we want to do is to get the community antibiograms. And in order to get the community antibiograms, you have to link up you have to get the data from somewhere. So it would be from here, it would be BC CDC, I think, or the Ministry of Health. But this is possible to do if they actually have the health data platform running, which they are working on it. So I do see that as a possibility. Does that answer the person's question?
I'll let Lori reply if she has further questions. She said thank you.
Oh, okay. Okay.
Any other questions from our audience here? Sabrina.
Oh, right. Yeah.
I'm curious about the funding issue. I know you struggle with that. But it seems like since this is such a huge investment federally and provincially,
then it should just be a given, and it shouldn't be grant, and, you know, they have to keep writing grants to get
Right.
funding.
Yeah.
So
Right.
what is kind of the political position on funding something like this? Because it seems like it should be through the government.
Well, yeah, you'd think so, but I think the government has so many priorities that they kind of need to figure out a way to sift through their different priorities. And I think there would be a lot of thinking about, okay, is this a priority compared to activating the primary care networks that are going in place?
It seems like to be part of the program.
Yeah, yeah. So, I mean, you're asking about, so there's another kind of, so there's the primary care Sentinel surveillance network. And then there's this other thing in the environment that's called the Health Data Coalition that also extracts data out of EMRs. And so there's a lot of hotly debated, what do we call it? I'm losing my words, but they're not sure which one they should choose. So as there are multiple different vendors for electronic medical records, there's these two vendors. So one is university-based, and it's the Citizen, and made by researchers as well as physicians, et cetera, et cetera. The other one is backed by Doctors of BC. So there then becomes this sort of political environment, which it would be a whole conversation to get into. So yeah.
I remember that from Chester last year. The only reason we're bringing it up is because I think that it would be a horrendous loss of effort and money because of this dispute that's going on. And I just think everyone should be a little bit more aware of it and what's going on.
Yeah. Yeah, well.
And I didn't know until I went to Chester last year, and there was that business going on with the doctors in BC, where they were actively promoting the competition.
Yeah. Yeah, they're still actively promoting. They're still actively promoting their thing, but you know, they've invested a lot of money. So from their standpoint, they want to promote it. And I think we all struggle in an environment where, you know, we want to promote something. Because there's been a lot of investment in it, and then there's other people who maybe don't feel the same way. I think there's always these tensions, right, between.
But I think the other thing too that I also noticed, because when we were at Chester last year, there were only a few nurses there, right? And we were there, of course, percent of the work, but it was very heavily physicians, and I think that as we're going towards team-based care.
Yeah.
Like if it's a Doctors of BC product, is it really going to be team-based?
Yeah.
So it's just another comment.
Yeah, yeah. So that's a good comment, and I forgot I wanted to say what I thought roles could be for nurses and nurse practitioners, because I wish there was more nurse practitioners here today, because I think, you know, this is really relevant to them as prescribers. This is a tool. I would really love their feedback on whether this is something that they would use, and they would help to develop this tool. I also think that nurse practitioners could lead practice QI in terms of AMR to examine what's going on with the CNS's prescribed medications, and then also to contribute to surveillance systems. So just as we contribute to the flu surveillance systems or syphilis, this would be another kind of surveillance, right, in terms of the communicable diseases. And then nurses, I think they're particularly well suited for sort of the data quality management. So what is the data going into the EMRs, and also in-house analytics. So this is where, you know, your research course at the undergraduate level is giving you a taste of kind of the things that you would be able to do as a nurse with the back end of looking at the statistics and understanding sort of what's the trend in terms of the CNS stuff, or what's being prescribed for UTIs, et cetera. completely within the scope of practice for nurses, and then also to help develop that AMR system. So nurses are really the ones that are doing much of the surveillance today. At BCCDC, they have the whole range of nurses that are doing all the kind of surveillance in terms of chlamydia and HIV and syphilis, and they're the ones that are the ones contacting the physicians' offices in terms of primary care. So yeah. Yes.
Is that, excuse me, is that certified? Like, do they have to have certification to do that surveillance work?
Not the surveillance work. They have to be certified because they end up doing some diagnoses of specifically the STIs. And then also they're allowed to then also prescribe for treatment for those particular diseases. Yeah.
So that's an RN.
Yep, that's an RN with the, whatever the, I can't remember what it is. It's like a specific
It's a
certification that you get on the end. Yeah. 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 Yeah.
I have to admit, I remember us working in public health nursing and in our students, with our students around the campaigns around do bugs need drugs, and ways to try to encourage people to not pressure clinicians for an antibiotic when we know it's viral, or things like that. And I think people are beginning to recognize some of the other places of antimicrobial resistance, like the number of antibiotics and hormones that are fed to animals to help them grow and grow faster and grow bigger, and that's a key source of resistance. And people are voting in a way with their pocketbooks around the choices at restaurants and things that are moving in that direction. But I have to admit that the news I hear, or the information about antimicrobial resistance, is really daunting. It's one of those stories that people should be really like alert, 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 and yet we mostly just pay attention to it once in a while and then mostly forget it. And I think that this is an area that with the shifts in climate change, with the increasing use of such antimicrobials, we are going to be in new territory. And so these kinds of strategies that help people both change that behavior that leads to further resistance, but also to help us identify the most effective antibiotic or antimicrobial the first time around, rather than having to do trial and error first, is a really innovative approach to thinking about how to do this. So very cool.
Yeah, we'll see. It's really interesting. The microbiologist on our team is like, well, there's not really any good tests because, of course, UTIs in the community, everybody in long-term care has a UTI, essentially, if you tested them. So the technology to look at these things isn't very good. And the other one, so there's two other ones. So UTI, and then there's pneumonias, and there's also cellulitis. And all of these things, nurses are very, very aware of these things, but we actually have no good tools in terms of testing for culture and sensitivity. So that's why we need to work with engineers and microbiologists and other kinds of people, because this is a big problem, and I'm just trying to put a team together to try to figure out, okay, there's just so many different parts. There's the behavior management and the change management and the theories that go along with putting this into place with the cognitive load, and then there's the technology part and how do you diagnose that and get that into the hands of the right people. And then there's the informatics part on the other side, and the data visualization, which is really what clinicians need, because they hate looking at tables. They can't stand it. And they also don't like looking at a ton of numbers. So, you know, that's where we need all these different people's help in doing this. And for you that are students in the room, like this is something that you guys could be working on in terms of, you know, once you get your clinical skills, you know, all set the way that you want them to do, I think this is an area that could be really, I think nurses could make a big difference. Yeah. Morale?
I'm just curious in terms of the way that the tool works specifically. Does it include data that would come back on the responses from patients and how the specific antibiotic or whatever medication was given worked for that particular diagnosis?
Yeah, so no, not at this point. Something that could be incorporated, but yeah, we were just trying to make a primitive tool. Yeah, but that's a good point. Yeah. And I think, you know, it's a big deal. So we think about social determinants of health, we think about inequities, and we think there's a lady or I should say a professor in the School of Public and Population Health. And if you think about the amount of what happens with antibiotics, right? So they come out of people's bloodstreams, and you know, they end up whatever, there could be extras in the garbage or whatever, and then the rats will get into this, right? Because it gets into the water supply and et cetera, et cetera. And then the rats actually, of course, they travel. And then the professor, I think she found it, right? She went, she followed the rats, and they go downtown and to the downtown east side. And then you'll see that there's higher resistance rates in that particular area because of some of these environmental things also that are going on in the environment. So if you think about people living on or close to the street, they will have different resistance rates. And they're the people that are coming in sometimes for, you know, cellulitis, that kind of thing. Yeah. Yes?
I have another online question from Laurie Block. How do you see nurses contributing their data to this work, which describes the early signs of infection, example, wounds, and related interventions, example, topical antiseptic wound dressings?
Yeah, so we just have to figure out where that would go in the electronic medical record. And the electronic medical record that the public health nurses are using, or the home care nurses, I don't know where that sits. But that's also that would actually be really great if we had that data, and we had data from the primary care and then the hospital, right? So if you could imagine the information infrastructure underneath, and then you were going in there as a researcher and you wanted to see all the different things about, we know this is a cohort of people that has cellulitis. What are the kinds of things and that was described around those people and their treatments? So yeah, I'm working with a clinic right now, and they're very interested in understanding how do we record social determinants of health. So it's not just around billing, but it's around social determinants of health, around housing status, poverty, et cetera, et cetera. So there's these things called V codes, and we're trying to figure out where do we put them in the electronic medical record. And because they're setting up their EMR system, we're also working on, okay, well, we will pull them out of this area, and all of that we're trying to work on how then do we report that to the Ministry of Health. So this particular clinic is an NP-led clinic, and they have to report to the ministry every 2 weeks about, you know, the number of people they see, the number of people they attached, et cetera, et cetera. So we're trying to set their system up as they go on. So I think that nurses can really contribute to what gets recorded, what gets put into the data, and then what gets reported out. But it really is going to take them to say, okay, we're really interested in this, and this is how we can use the system that we have today, until we can then have other people say, okay, no, this, we can use natural language processing or whatever.
It sounds like Larry has some ideas. She says she can help. So
Oh, good.
you guys can connect afterwards. Any other questions from our audience here? Can I ask a question for myself? And that's, I'm just wondering a little bit more detail about how the hackathon worked, and whether it was obviously focused on AMRs, but are there applications that we could use here at UBC for hackathons that would be something for nursing to use as a tool?
Yeah, I think you can use hackathons as an approach to any kind of problem. The company that did it does hackathons all the time. So, it's literally a setup where you have a bunch of people coming together in a concentrated period of time, and they kind of basically don't leave. And then you just feed them all their meals, and then they work on the problem. And then you can set up a panel of judges to understand if that is something that can work.
Yeah. UBC does host some health hackathons. So nursing has really connected to that yet, but might be something to think about in future iterations of it.
Yeah, it might be a way that we think about, how do you set up a nurse practitioner clinic or a new model of care? Just do it over one weekend and get it done. It's amazing what you can do with a group of people who are all motivated to do the same thing, and to take the ideas and turn it into that. I just thought, wow, that's really cool. And I think the beauty of the hackathon was working with people who don't think like me. So I really was there to meet people who had different ideas, different experiences. And in fact, the informatics, the two guys are from Germany, and they're actually doctoral students. And so the hackathon just leveled everything. It wasn't like, okay, you're a professor, you're a physician. It wasn't we didn't care about anybody's position. It was just like, here's your expertise, and yeah, let's go to town. So we literally said, here's the data, and this is what we want. And they're like, okay. And they just, we're doing stuff. So that was great. They were using their expertise. And the same thing with the data viz guy. He wasn't a doctoral student, but yeah. So everybody in the hackathon, what worked really well is everybody had their expertise, and everybody there was an expert. There was no one that was kind of like, I am the guru kind of thing. I think the other thing that was really neat was that they had sort of mentors who were kind of more the content experts. So we had a couple of talks to kind of start it off, in terms of trying to give a lay of the land of antimicrobial resistance. That was helpful too. And then everybody had to wear the same T-shirt, which helped. Yeah.
Thank you to Sabrina for sharing her experiences and her expertise with us.
Thank you.